Centralized sensitization or centralized pain syndrome, as Daniel Croft would call it, is probably the one that is the biggest challenge to us. Yes. Particularly because this group of diseases is associated with enthesitis. So I know that centralized sensitization is a very strong interest of yours, Philip, but either Atul or you, can you answer how you would go about objectively evaluating patients where that is in the differential diagnosis versus inflammatory disease, that is the enthesitis component?
Well, as you allude to, Sergio, it's very tough. One of the things that we're starting to move toward is use of validated questionnaires that patients and physicians will fill out together, such as the Widespread Pain Index and Symptom Severity Scale that was developed by Fred Wolf, Dan Claw, myself, and others, and published first in 2010 and most recently updated in 2019. There is also a few questionnaires that have been used in other types of studies, including the Pain Detect questionnaire, or one called the FIRST, F-I-R-S-T questionnaire. And if you have an elevated number of responses in these questionnaires, then it's suggestive that you have central sensitization. The most definitive way is not practical in clinical practice, and that is to do neuroimaging. fMRI scanning, there have been studies even with PET scanning where you can see certain changes in the central nervous system that are consistent with central sensitization, but this is not practical for daily practice. And then the other part is looking, is there any evidence of inflammation still going on? What's going on? If the CRP was originally elevated in the patient and now it is normalized, or if there was very active light up on an MRI scan and now it is normalized, that could be of interest in helping you understand how much you've controlled the disease with immunomodulatory medicines. But even those have to be taken with a significant grain of salt. It's not recommended, for example, that we do serial MRI scans looking for inflammation. It's not recommended to always be doing CRP testing because oftentimes CRP is normal, even in patients with very active inflammation. So I'm afraid that you've hit upon an area that we still are not quite there yet in terms of being able to accurately distinguish the presence of inflammation versus central sensitization.
What about the use of ultrasound? Atul, you look like you're going to jump out of your chair there.
I was going to jump into that, and so your question also was about the especially about enthesitis, and
right.
Enthesitis, and Philip calls it sometimes enthesalgia, which is pain and tenderness when you press on these areas. I think the objective enthesitis I have seen is mostly at the heel, and that's why the definition of enthesitis in the SAS classification criteria is at the heel. Patients who have got central sensitization very rarely would have plantar fasciitis or Achilles tendon insertion area pain. Again, some people would have it, and very commonly plantar fasciitis and Achilles tendon insertion pain can be because of obesity and being overweight and standing and your job and etc., etc. So that also is not very specific. Rarely in these situations of patients with axial spondyloarthritis, you can actually see evidence of inflammation by examining that area, and it is generally asymmetric, and you can see one part of the Achilles tendon where it inserts literally bigger than the other side. If you tap on their plantar fascia insertion into the heel, into the calcaneum, they have tenderness more on one side than the other. And that is, I would say, an objective evidence. Beyond those, clinically, to differentiate between enthesitis because of inflammatory rheumatologic condition versus central sensitization is very difficult. ultrasonography, as you rightly said, is one area where people can, one has to be very skilled at that. And I do ultrasound myself. I can find a needle when I'm doing joint injections into various parts, and I do hip injections and et cetera, with ultrasound. Having said that, the ultrasonography of the enthesis is still an art, and a lot of education needs to go into that. There are certain parts of the human anatomy which are suitable to do ultrasound to find enthesitis. The axial skeleton is not one of them. Axial skeleton enthesitis, which is major part of the Macy's enthesitis tool, those are not very accessible, or I would say definitive, whether you do ultrasound or even MRI scan for that matter, and that does not differentiate. I just want to go back a little bit and about this discussion that Philip had about central sensitization and fibromyalgia. The difficulty that we have is just because somebody has fibromyalgia doesn't mean that they don't have axial spondyloarthritis. You can have both, and about 30–40%. And he mentioned that that's one of the comorbidities. In that situation, if you have a patient who you know has fibromyalgia, and then you're thinking, does this patient also have non-radiographic axial spondyloarthritis? In that situation, I would say that the bar is higher for us to show evidence of objective, there has to be an objective involvement of the musculoskeletal system in an inflammatory process. So, and this is one of the issues of diagnosing, the difficulty in diagnosing and why there is a delayed diagnosis, is that rheumatologists are used to seeing swollen joints in the periphery. They're used to seeing, effusions and synovitis and etc. Here in non-radiographic axial spondyloarthritis, the area of interest or the joint of interest is in the spine, that you really cannot examine whether there is inflammation or not. And if somebody already has fibromyalgia and mechanical backache, then you have to look elsewhere to look for definitive evidence of inflammation clinically. And one of those areas would be the heel and plantar fascia and other things like uveitis and IBD and psoriasis, etc. So, or peripheral inflammatory arthritis again. So that is one of the issues that we face in daily practice, differentiating between fibromyalgia, central sensitization, and coexistence of non-radiographic axial spondyloarthritis, or only one of them.
Thank you.